Welcome to all of our smashers to our fireside chat today. We are so happy to have Dr. Laura Alder from Duke joining us, and Dr. Shields will introduce her. But before we get there, I just want to say that I hope that all of you have registered for our Smashers Live event that's going to be held in Dallas that first weekend in May 1st through the 3rd. You can find the registration link on the lungevity.org website, and also to know that many of those sessions will also be live streamed. Dr. Shields, would you like to introduce Dr. Alder to our community?
Wonderful. Thank you, Anne, and welcome to our Smashers. What a beautiful Friday here in Indianapolis. It's almost like, I think, 60 or 70 degrees, beautiful and sunny. Hopefully you have warmer weather where you are. I get the privilege and pleasure of introducing a close friend and colleague, a world-renowned expert in small cell lung cancer and brain metastases, Dr. Laura Alder. Welcome, Dr. Alder.
Thank you so much, Dr. Shields. I'm so happy to be here today talking with you on this really important topic.
Lovely, lovely. So let's dive into her bio. Dr. Alder is an assistant professor of medicine in the Division of Medical Oncology at Duke University Medical Center, where she serves as a member of the Thoracic Oncology Program, Medical Oncology Deputy Director of the Duke Center for Brain and Spine Metastases. Her clinical research and expertise focuses on advancing treatment options for patients with lung cancer, with a particular emphasis in patients who are impacted by small cell lung cancer, brain metastases, and advancing biomarker-directed therapies. She has been a PI for the site in multiple trials that are looking at advancements for patients with small cell lung cancer. She's also been focusing on real world outcomes, which we heard from Dr. Sonam Puri with Onward Small Cell. She leads that effort at Duke, really focused on patient-focused endpoints and patient-reported outcomes, and also translational efforts. We are very, very excited to introduce her to our Smashers today. Welcome, Dr. Alder. Thank you for being here.
Yeah, thanks so much for having me, Dr. Shields, and for that introduction. And hello to all the smashers out there. I'm so happy to be speaking with you today.
Well, wonderful. Let's hop into this. So today we're really be focusing about brain metastases or brain mets. Um, to kind of ground us and ground our smashers who this might be possibly a new conversation or concept. What are brain metastases? Can you explain that for us?
Yeah, it's a good question to begin with. So with any type of cancer, and we're focusing on small cell lung cancer, it's when that cancer that starts in the lungs spreads to the brain tissue. And so it's still the same small cell lung cancer, and we treat it with the same types of therapies that affect from head to toe. And unfortunately, while it can happen in a lot of cancers, the rate is high, especially in lung cancer and especially in small cell lung cancer.
Can you
And
tell us a
yeah,
little bit, Dr. Alder, as to
yeah.
why that is? Why in lung cancer and small cell in particular, is the brain such a sanctuary for metastasis to go?
That's a really good question. We're working really hard to understand better some of the disease biology, the genomics, we talk a lot about DNA, and that's kind of the instruction manual that tells the cells what to do, but also some of the proteins that are expressed, the way that the tumor behaves. We know every single type of cancer behaves so differently. And for whatever reason, sometimes some of these lung cancer cells can really do a good job of getting past that protective layer in the brain. It's called the blood-brain barrier. Some cells can be really good at just kind of breaking down those blood vessels, breaking down that wall of protection, and getting into that protected site. And one of the things that I'm really excited about doing with some of my colleagues in the bench work and with different modeling of not only small cell tissues, but also brain tissues of small cell tumors that go to the brain to really analyze what's unique, what's different about them. Because I think that will really help us to create better treatments and better targets. I hope that answers your question. Still some
Right.
unknown.
Yeah.
But working hard to better understand just that question.
Yeah, and just to highlight for some of our smashers, remember Dr. Alder is at Duke, and we know that Dr. Trudy Oliver is also at
Yes,
Duke, so she is a big collaborator with you, right? And
she
we heard
is.
we heard about our smashers heard about Dr. Trudy Oliver's work with the origin of small cell. We had her
Yes.
on a few months ago, and so just to put it into context, Dr. Oliver and Dr. Alder work closely together at Duke in this kind of mastermind of understanding small cell lung cancer. Is that right?
It is, and it's so exciting, because she's doing such exciting things in the lab, and we're working really hard to bring that to the patients, to you guys, and to develop some, early phase clinical trials, looking at some of the exciting developments. So stay tuned. Hopefully, in the next year or two, we'll have some novel treatments.
We're looking forward to it. We'll have to have you maybe both back on here to talk about it. That would be
Yeah.
lovely. So, as a medical oncologist, and you are also as well, Dr. Alder, thoracic medical oncologist, focused in the treatment of helping patients with who are impacted by small cell. Uh, Tell us a little bit more. So, do patients who have brain mets, they always have symptoms? And what symptoms do they have if they have symptoms?
So it's a really good question. To your point, they don't always have symptoms. And one of the things that thankfully has become much more established is MRI or CT brain images. So taking pictures of the brain, both at initial diagnosis and throughout the course of the disease. And so usually that's done, again, an initial diagnosis, and usually about every 3 months or so, because we really want to keep a close eye on the brain. We want to make sure we catch things earlier rather than later, because then we have much more treatments available, and those treatments are better tolerated too. And so sometimes those pictures can tell us really small lesions that you may not even know that are there. And other times there are symptoms, and these can include headaches. They can include vision disturbances. They can include feeling kind of weak, especially in one limb or another. Sometimes it can even feel a little bit like a stroke, which can be really scary. Any confusion, any trouble walking or balance, nausea, vomiting. What I usually tell patients is, if you know your body best, if you feel that something is new, something's not right, please communicate that to your doctor, to your nurse practitioner, to your nurse. We have such a great multidisciplinary team because we always want to know, and nothing is too little.
Yeah, I can't echo that enough. And, it is hard on the flip side when we have, our patients, sometimes a headache is just a headache too, right? You're allowed, you go, oh, is my hair too tight in my ponytail, right?
Yeah,
Is a headache just a headache? Did I have my coffee today? But if it's something that's severe, it's persisting, it doesn't go away despite medicines, those are ones that kind of are red flags for us to say, maybe I should tell my team, right?
absolutely.
Life still happens, right? We still can have
Yes,
other things happen, but we really do want to make sure that you're checked out if it's something that's ongoing and or bothersome.
absolutely.
Um, you kind of touched on this. Can we dive into this more about the role of imaging for areas in the brain, right? So
Yeah.
how are they commonly detected? You kind of mentioned this about these images and scans. What's the gold standard for detecting areas in the brain like brain mets?
Yeah, thanks, Dr. Shields. So this always comes up. So the gold standard is a specific type of scan called a brain MRI. And what that does is uses these special magnets, and it really provides a great view of all the brain structures. One of the common things that people ask is people always get a CT scan or a PET CT scan, and a PET CT scan is from head to toe. And that uses a sugar dye, but the brain loves sugar. We all do a lot of thinking. It takes up that sugar. And so the brain always lights up. So we always need a dedicated image of the brain. And so either that's a brain MRI, and sometimes that can feel a tiny bit claustrophobic. It's a little bit of a smaller donut you go through, but we have really good medicines if anyone has trouble with feeling a little bit closed in spaces, give any anxiety, which is fair. And then the other mode of taking pictures of imaging is a CT scan that's dedicated to the brain. And that's nice because if anyone has any metal, any pacemaker for the heart or any other reason, CT scans are also very good, a little bit quicker. But the great thing is that these can give us a really good visual of what's going on. And as I mentioned, we do that through the course of most types of lung cancer, especially small cell, because we want to, knowing is always better. And then we can tackle things together with whatever comes up along the way.
And we actually have a question from our audience. And how long could you possibly have brain mets before the MRI might pick that up?
That's a really good question. We know that small cell lung cancer can move quickly. And so things can grow quickly. And even though our scans are great, sometimes if things are too early to see on one scan, a lot of things can happen in 1 or 2 months. And that's why, as Dr. Shields was mentioning, and I mentioned as well, if there are new symptoms like headaches are constant, not going away, or anything that we discussed, it is so important to tell the team because then we can certainly move up one of those brain images to make sure that we're not missing anything and to help troubleshoot, what could be going on. Some of our therapies can cause headaches or feeling dizzy and things like that. But at the end of the day, we want to support you all. We want to support our patients and their families and make sure we find out what's going on.
Yeah, I absolutely love that. And if we detect it early, and then we can have a plan together to help best support our smashers. This is something that really has come up many times, I think, across our smart smashers Facebook group, and really understanding how often should these scans be getting done. Sometimes some of our smashers are getting them done once a year, or only at diagnosis, or so I think you kind of touched on this, but how often should patients be getting scans, and does it matter if you've never had brain mets?
Good question. So like most things that can be a little bit nuanced. So let's say someone comes in with brain mets, and let's say that we made the decision to start treatment first. And we'll probably go into this when we talk about, these IV treatments that we have. Um, I always like to be extra cautious. And so if we do treatment first, I like to get another brain image in about 4 weeks, or 4 to 6 weeks after 2 cycles of treatment. So that means 2 doses. I want to make sure that the treatment is working. I want to make sure that the brain lesions are shrinking. And because if they're not, we can always go towards radiation, which we'll talk more about later. If someone does not have any brain mets, still like to keep a close eye on it. Usually that schedule is every 3 to 4 months.
Mhm.
And that's regardless of treatments, regardless of anything else. Because as we both mentioned, catching things early is key.
Yeah, and sometimes I sometimes I tell my patients if things change in the body, we should always check the brain too, right?
That's
If
a
the
great point too.
cancer's ever growing on the scans in the chest or in the liver or whatnot, if there's change in the body, we got to check in the brain. So anytime we see that, usually is kind of a trigger too. But I think it's so important, and sometimes I think there's been some of our patients that have had questions of just, should I be getting scans? Is if it wasn't there before, why should I check now, right? And so I think it's important that as we follow these scans, that we really are checking everywhere, because those PET scans don't check the brain. Which is why I tell myself I can have chocolate because my brain needs the sugar. So, um,
Absolutely.
One of the other questions that has come up is, what is it that you actually see on the MRI about symptomatic brain mets? And question came up about why did my doctor feel like I needed to start steroids right away? So can you just talk a little bit
Yeah.
about what you actually see on the MRI and how that translates to symptoms?
Yeah, great question. And for all the smashers, it's always okay to ask your doctor or anyone to like, hey, can we go through the images together? Because
Mm.
sometimes a picture is worth 1,000 words. And so on these brain images, how as you go through the scan, they kind of take slices. It's kind of like slicing through a loaf of bread a little bit. So we see these kind of slices through the brain. And so we get the images, the pictures of all the brain tissue. And when there's cancer, that's, mass, lesion, tumor, all the same terminology for what is kind of a solid thing in the brain that's cancer that shouldn't be there. We can see that on these pictures. And sometimes because that kind of that mass, that tumor is taking up space, there can be some swelling because the brain is a sensitive area. And we can also see that on the pictures. And because that swelling is there, that can actually cause some of the symptoms that we've talked about before. And steroids, that's one of our go-tos to bring down the swelling. And that can help our patients feel a lot better immediately while we plan for that treatment, whether it's local radiation and zapping that lesion or whether it's an IV treatment that can work hopefully head to toe.
So important, the role of steroids, and that's why sometimes if a
Yeah,
patient comes to the ER and they have symptoms, we might do IV steroids to try to get things even quicker,
yeah,
and getting the swelling down so that we can help patients feel better, within a day or a few days, right?
absolutely.
But it
Um,
also highlights again why it's really important to report these symptoms to your physician, because
right.
if that is found and they do see that on the pictures, they can do something that will make you feel better really quickly.
Yes.
Correct, correct. And so even our our smashers and our care partners, their loved ones, if there's something that's a little bit out of sorts, that making sure you chat with the team so we can best support you. Uh, let's take a little bit of a detour here for a split second and talk about how do we how do we prevent brain metastases? One historic way for a long time was something called PCI, or prophylactic cranial radiation. What is PCI? Can you explain that to us? And then what was the role for PCI in small cell lung cancer historically?
Yeah, good question, Dr. Shields. So, PCI is prophylactic, and that means preventative. Cranial brain radiation. And so that's kind of low dose whole brain radiation, which is a treatment that we sometimes have in our back pocket if we need it for those who already have brain mets, but it's a very low dose. And by kind of preemptively trying to prevent giving low dose radiation, it kind of kills any cancer cells that could already be anywhere in the brain environment. And there were some studies, one thing to highlight, and we'll talk about this throughout the entire show, is we've come so far in small cell lung cancer. It's such an exciting time. There's been so many breakthroughs. Um, but historically, PCI was shown to help prevent brain metastases, especially in limited stage. So early stage small cell lung cancer that can be treated with surgery or chemotherapy and radiation. Usually that means it's in kind of one field of the lung there. That's been shown to historically offer improvement. And even historically some overall survival, so patients living longer with it. But excitingly, nowadays, we have immunotherapy, immune checkpoint inhibitors that work with your own body to better fight and kill the cancer from head to toe. We know that a lot of these immunotherapies do get into the brain, do get past that blood-brain
Mhm.
barrier, and do a much better job than before we had these treatments of preventing brain metastases. That in conjunction with what we've been talking about with these surveillance, which getting the brain images every couple months at disease progression, the big question nowadays is, do we need PCI? Because it's not without side effects. It can make you feel kind of crummy. It can make you feel tired. Sometimes the way that you think, especially higher level thinking, can be a little bit affected. It differs, person to person. So thankfully, we do have some exciting clinical trials. One of them is a cooperative group, many sites, academic community called Maverick. They've actually finished enrolling, and so now they're working on reporting that data, analyzing. And so I think there's more to come. But given all these exciting treatments, I'm hoping that, we can make very cautious decisions to really put our patients first and make sure we give the best outcomes and really lower the toxicities too. So excited to see more of that data.
Does it matter, Dr. Alder, whether you're limited stage or extensive stage as to whether you would consider PCI?
Great question. Nowadays, for extensive stage, I don't think any of us are discussing PCI. For limited stage, it can sometimes still be a discussion with radiation oncology, with medical oncology. Um, it certainly can still be a discussion.
Yeah, and I think we're all eagerly awaiting Maverick, which included both limited and extensive stage, to really see. But I know as Dr. Alder obviously has pointed out, with extensive stage, there was some data out of Japan, a big phase 3 study that showed no benefit over MRI surveillance, did not help patients live longer, did not make any difference. So why would we put patients through this? And so it really called into question. And so I think we're eagerly awaiting the Maverick data to really, hopefully solidify this once and for all. So um, switching gears here, I know we've touched on this a few points and hinted at it, but I'd love to get into treatment of brain metastases, right? There's so many options, and we're going to go through each one and pick your brain. But can we kind of talk about, on a high level, what are options if a patient saw an area that was new on the brain and discussed it with their team? What are options for treating it? And then we'll kind of go into each one. What are some general options? Is it surgery, radiation, chemos, et cetera, right?
Yeah, great question. And one of the things I always really like to highlight is the importance of a multidisciplinary team. And I know Dr. Shields at Indiana, you all have a tremendous team there. At Duke, we're very fortunate to have the Brain and Spine Center. And within that, we have a neuroradiologist who helps to read brain scans, radiation oncology, who helps with radiation, especially on radiation doctors who focus on the brain. We have neurosurgeons. So I think that team approach is always important. One of the things, there's a few ways to kind of think about it right away is one, how symptomatic is the patient? What are they feeling? What are they experiencing due to these brain mets? How many of them are there? Is there just one? Or are there just a few? Or there, many? And then we can start thinking about what's the best treatment for that person sitting right in front of us. And so if there are, only one or two, then maybe we can think about surgery in some cases and removing them. It's definitely a discussion. Another really good option for few to, low many, that number is adjusting a lot, is very focused radiation, which is often very well tolerated. If there's many, then we have different types of radiation to make sure that we can get them. And then, of course, we have all the systemic, the whole body treatments that are IV treatments, a lot of which show really exciting and really promising activity, both in the body and in the brain.
So thank you for that overview, Dr. Alder. Can we dive deeper into this? I know you're a medical oncologist, not a radiation oncologist, but you know more than the average bear about radiation oncology. Can you walk us through what are some of the radiation options? Our smashers may have heard or experienced whole brain radiation. You mentioned some of these targeted radiations. Can we walk through what does whole brain entail first, and
Yeah.
what is when do we use that? Why do we use that? What are side effects, benefits, and the sorts?
Yeah, great question. So whole brain, as the name implies, is delivered to the entire brain. There are some new techniques coming out nowadays that spare a special region. It's called the hippocampus. It's kind of like the memory center of the brain. And so radiation, along with all of our systemic treatments, is getting better and better. Our technology, the way that we deliver it. So that's been great too. So with whole brain radiation covers the whole brain, and that can be important. Every patient presents a little bit differently. If there are many, many, many brain mets, and whole brain can be a really good way to treat all of them at once. And so usually it's over 10 days that you have to come Monday through Friday. And usually we have really good social workers, supportive care at a lot of these centers. Um, and I would say, there are some side effects. And so sometimes that can affect some of the higher level thinking processes. So sometimes there can be kind of a little bit of issues with memory after whole brain, and everyone's different. Some have more than others. Sometimes attention span can be a little bit different. There can be tiredness during or after the whole brain radiation. There can be some hair loss. Usually that's temporary and it will grow back. And then there can be some long-term, it's called neurocognitive, again, like it's kind of the way we think and process information. There can be some long-term effects. There are some things that we try and add, like memantine. Some of you may have heard of. It's a pill that can help reduce some of these neurocognitive, some of these thinking side effects later on. That's pretty promising. Um, but it's still a good therapy option. You may have heard of also whole brain related to brain mets is leptomeningeal disease. That's when the cancer gets into the membranes or like the lining of the brain and the spinal cord. And we also have treatments for that too. And whole brain is one of the really good treatments we have for that as well, either to the brain or the spine, including like the spinal cord where your nerves live.
And I know many, as mentioned, many of the therapies, like even, tarlatamab that we've heard a lot
Yes.
about, and I think I'll pick your brain in a minute on, but a lot of the antibody drug conjugates, they have activity in the brain. So, is that effective for leptomeningeal disease? I think that's a really good question for us to study and to know, right? Is that helpful for our patients? Can they avoid even radiation possibly in those cases?
Absolutely.
Um, Dr. Alder, tell us more about targeted radiation. So, like, some of our semesters may have SRS or gamma knife or
Yes.
right, proton therapy. Give us kind
Yes.
of an overview of what that means. What are the different types? How many areas can we treat? What are the side effects? How long is the therapy? All of those things.
Yeah, great question. So SRS or stereotactic radiosurgery, but there's no surgery involved. And one of the types is gamma knife, but there's no knives involved. So that's always important to point out with some of these terms. But they're a highly focused, really, the radiation oncologists, they have amazing technologies. They really pinpoint exactly where best to deliver these high energy beams that directly kill the cancer exactly where it is. And that's really nice because it decreases some of these side effects that we talked about for a whole brain. And proton therapies is one of the exciting advances that I'm really eager for. It's another similar to SRS gamma knife. It's highly focused, highly pinpoint. I think one of the exciting things with protons is it even spares some of the surrounding tissue a little bit more so than some of our current methods. So even less side effects, more pinpoint. And as I mentioned, the technologies have improved so much. So before, the estimate number of lesions would maybe be three, four, five, but now I've seen upwards of 10 or more at our center. And it's amazing. And Again, usually it's really well tolerated.
Yeah, I've seen sometimes 15 or even 20 as well. You know, all of radiation is really so mathematical and physics based that all the plans that have to be done, you know, for patients and treating patients are all double, triple, quadruple checked by dosimetrists and physicists and the radiation oncologists, and to really make sure it's safe and appropriate for the patient and what the risks are. I have one more question, and I'd like to pivot to kind of surgery here, but can you talk about radiation necrosis and what that is, and who might be possibly at risk for that?
Yeah, so it's a really good question, especially thankfully as our patients are living longer and longer, which is great. So radiation necrosis is basically dead tissue, and that can sound scary, but the point of radiation is to kill the tumor cells. But sometimes that can create a little bit of inflammation. And some of that dead tissue can create some irritation in the brain. And so that's also, and sometimes it can be scary because it's not always clear if what is happening in the brain in some of these scans or because of post-radiation changes or cancer related, like cancer growth or cancer changes. Thankfully, some of our scans are getting better and better at helping us to figure out which is going on. And a lot of our radiologists are also very good. And so sometimes that can cause symptoms, though, kind of similar to what we were talking about with steroids and inflammation when there is kind of that irritation and swelling in the brain. But thankfully, if radiation necrosis does happen, we have good treatments, one of which is steroids that we talked about before. And another one is an IV treatment. You may have heard of it as like Avastin, bevacizumab. And what that is, it helps to kind of decrease the blood vessels from growing as much in certain areas. And by decreasing some of that blood vessel growth, it can decrease some of that inflammation in the brain related to that radiation necrosis. And that is usually a very well tolerated treatment. It's every 3 weeks or so, and can really help with the symptoms.
Dr. Alder, when would you actually refer a patient to a neurosurgeon and actually do surgery to remove a brain met?
Yeah, so we definitely want to be cautious. We want to really be aware of what's happening in the whole body. And we want to make sure that surgery would be, in the best interest. So when we think about that is, let's say there's one lesion that's pretty large. Because it's large, it's causing a lot of pressure in the brain. Um, it's causing some neurological symptoms like we talked about before, trouble walking, dizziness, constant headaches. And let's say that the rest of the disease is under really good control, a really low burden of disease, or they've been on a treatment like tarlatamab that's been working for months and months and months. Then, it might be the best idea just to take out that brain lesion and then after we do that surgery, and I say we, I don't do it, but after the brain surgery, then the radiation oncologists deliver radiation to the tumor bed to where that was taken out to make sure any cancer cell that could possibly be left over is gone. And that can be a really good way of getting rid of that one brain lesion. And I'm sure we'll talk about this more, but if someone is having a really good response to any treatment, then either surgery or radiation and continuing that treatment is always a really important discussion.
That's so important. We call that oligo progression, meaning, just a handful of sites, in one organ or maybe in two organs that have popped up while on an effective therapy that was working everywhere else. And so that oligo progression should be treated with what we call local therapies, which would be something like radiation or surgery, as Dr. Alders discussing, and then riding the wheels off of the therapy that we are still on, right? Because we want therapies to last and last. And if there's a single, rogue cell that escaped, we can try to treat it and go back to the therapies, closely watching those areas. Um, and so, Dr. Arter, we could probably do a whole Smashers Live on brain mets and our systemic or our infusion options that
Yeah.
go to the whole body. Tell
Yeah.
us about chemo and immunotherapy. Does chemo and immunotherapy or chemo or immunotherapy work in the brain?
They do. So yes to both, and then put them together, and it's even better, which
Right.
is what we do, thankfully. So nowadays, ether for limited stage after chemotherapy and radiation, we add on immunotherapy with a drug called durvalumab or Imfinzi. And then in metastatic or extensive stage, when the cancer is spread outside the lung to any different area in the body, a standard of care to get chemotherapy, usually carboplatin and etoposide, which I'm sure you all are familiar with. And we add on one of the immune checkpoint inhibitors, either durvalumab or atezolizumab, both of which work really well, both of which have improved survival rates, improved the time on treatment, and also have reduced the chance of brain metastases from occurring better. So that was a great development in the frontline setting, the first treatment that patients get. And if patients are treated in the hospital for the first cycle, then the immunotherapy is just added the first time they get to clinic, and that's great too. Um, but it's exciting because a lot of the immunotherapies, they work with your own body. So they work with like the army cells, your T cells, and other such agents. And these cells are already in your body. They already do a really good job of attacking all the bad guys, which shouldn't be there, like cancer. And so a lot of these immune cells can get into the brain. And we have to remember, with people already having brain mets, some of that blood-brain barrier, that protection is broken down a little bit. So it gets into there even a little bit easier. But even for people who don't have any brain mets, these immune cells are still capable of going to the brain. And the immunotherapy kind of teaches them to do their job even better than they normally do. So it's exciting.
Perfect. I love that. And, I think that that's why, for some of our smashers, maybe if tiny areas in the brain were seen on an MRI, your oncologist may say, let's try treatment first in case keep a
Mm.
close eye on it because they are likely to work, but just wanting to make sure we always are checking in on those areas to make sure nothing's ever going the wrong direction, like growing. So, okay, let's talk. I know, Anne, you probably want to pick her brain about tarlatamab, the new kid on the block, right? Tell us about tarlatamab. What is it? Does it work in the brain?
So great question. Yes, it does work in the brain, which I'm excited to get into soon. So this is another different type of immunotherapy. So it's also working with those army cells that we talked about earlier. So it's a bispecific antibody. And so what that means is it kind of has two arms. One arm reaches out and grabs the small cell lung cancer by its expression of a protein called DLL3. The other arm grabs those T cells, those army cells that we were talking about that express CD3. That's kind of like the name tag of the T cells. And by bringing them together, it helps the army cells directly kill the cancer, and it also creates this immune response that continues and helps the rest of the immune system continue to kind of be educated and kill the small cell cancer cells too. Um, and so that DLL3, that protein is expressed in upwards of 90% of small cell. It's so high, we don't even have to test for it. And so tarlatamab, there was a few studies. The big study that enrolled a lot of patients was Delphi 304. And that was a huge improvement because it really improved survival. The patients who responded to the therapy could have responses that lasted months and months and months. I personally have a handful of patients who've been on tarlatamab more than a year. So it's a really exciting treatment. It's the new standard, I would say, for second line after that chemotherapy, immunotherapy. There are some challenges that I would be remiss if I didn't get into a little bit. It does take time. Usually, currently, patients have to be admitted for 24 hours on the day one, and then a week later, on day 8. And then a week later after that, then they can get it in clinic. And then after that, it's every 2 weeks. So it's a little bit confusing with the schedule. I usually like make a calendar, but it works really well. There are some side effects we can talk about later. But the brain data, I think, has been exciting. So in the clinical trial, they did include patients with what's called asymptomatic, so patients who did not need steroids, who were not having a lot of the symptoms we had mentioned, untreated with radiation, or patients who did have radiation to the brain were allowed to go on this trial. We haven't seen from the phase 3, from the most recent, all of that CNS data read out. But it does seem from what we have that it's pretty similar responses to what we see in the body. And excitingly, there's been some really good real world experiences reporting on, in the clinical setting, off of trial, now that it's approved and we're using it every day. And so there's been a couple case reports. One of my Dr. Shields and I, colleagues and friends, Dr. Bingham Zhang, published a really nice case series of 10 patients with small cell lung cancer and untreated brain metastases, and one with suspected leptomeningeal disease. And clinical response, so a shrinkage in the size of those brain tumors or stability, which means not growing, no new lesions, which is still a big win, was seen in 90% of patients. So that was really great data. We've also collected a lot of our data at Duke. I heard you, Dr. Shields is with me with Dr. Hurry, with the onward small cell, and collected a whole bunch of real world, but our data suggests that it is at least as good as some of the rest of the body responses that we've seen. So that's been great. As Dr. Shields mentioned, when I see patients who have, small asymptomatic-ish, and I say ish because I think being on a little bit of steroids is okay. I don't think that's an exclusion by any means. I do sometimes treat with tarlatamab first and just keep a close eye on the brain. But I've seen patients respond. And then, especially for patients who may have had radiation in the past or who may not need radiation at this time, it can be a really nice way to just continue to have a good treatment radiation in the back pocket. But if we're gonna get a great response with this, and then that's great.
You touched a little bit on the side effects.
Yeah.
Let's talk a little bit more about the side effects. And
Yeah.
one question that we have gotten at LUNGevity has been that if you are being treated with tarlatamab and you have brain mets, how do you know the difference between some of those immune response reactions like
Yes.
confusion and headache compared to is that progression of the brain mets? How do you handle that?
Really good question. So the two side effects that we see, one is called CRS, that's cytokine release syndrome. And that's more of kind of whole body, but really more like non-brain, the rest of the body. And that's basically an immune response. Your immune system is so worked up and reacting to the drug that sometimes these chemicals are released as part of the immune response that can cause some side effects. The most common of which is a fever. And that can be treated, of course, with, some Tylenol fluid supportive care. That's the most common one. More rarely, we see some of the more serious side effects from these chemicals and this inflammation, like low blood pressure, like needing help with getting enough oxygen to your body. So, might need a nasal cannula or a face mask. I would say very rarely, 1 to 2%, unfortunately, may need the ICU to make sure that they get higher care medicines, IV medicines to help with blood pressure, extra help with breathing and making sure their body gets enough oxygen. Thankfully, that's rare. And then the other one, to your point, is more of neurotoxicity. And so that's called ICANS, which is a big name. It's immune effector cell-associated neurotoxicity syndrome. There will not be any quiz on the names later. And so what that can cause is the symptoms can vary, but to your point, that can cause confusion, fatigue, trouble thinking, in very rare, again, like 1% or 2% of cases, like seizures and more worrisome things. But to your point, a lot of these symptoms are similar to the ones that we mentioned before. And so, how do we treat ICANS or CRS? The first step is steroids, which we talked about a few times now. For CRS, the whole body, we have another drug called tocilizumab. It's another IV drug that kind of calms down the body. But steroids can work really well for any of those type of neuro symptoms. And so what our practice has been, and Dr. Shields, I would love to hear yours too, is if patients are experiencing these things, we want to give them steroids right away because we want them feeling better. But I really want to get another brain image because I want to know what's going on. What are we seeing? And in some cases, we do actually see a little bit of inflammation that's related to the drug. There's been a few case reports too that tarlatamab can cause not ICANS, but some kind of related neuro trouble, I guess. That's not really ICANS related, but it can cause some of these side effects just due to the drug itself. And it's patient by patient, but sometimes if we have to hold a dose to make sure that they're improved before they get the next dose, that's okay. We have a lot of really good supportive care. Again, steroids can be really helpful. Brain imaging can be really helpful, but we want to make sure that we know what's going on and we get everyone feeling better as soon as we can. Dr. Shields, I would love your experience as well with some of these.
Fantastic overview. I fully agree. And there's, as you mentioned, there's this new concept. We've seen it in other cancers. We're starting to understand it more in small cell, this TIAN, this kind of tumor flare, that as you'd have this effective treatment like tarlatamab, that maybe it's associated neurotoxicity because the treatment's working. And those are patients that we may get on the other side of it and like the spot on the brain is gone, right?
Yeah.
And so we just have to get patients safely through it. And so it's definitely nuanced and it's patient by patient and really that multidisciplinary team, as you mentioned. And so closely watching, we remember that the study's cytokine release was about 12, 13 hours. So really reasons why patients are in a close observation those first two doses between day 1 and day 8, where it really occurs in the first cycle. But ICANS can be median onset of 30 days. So it may be someone that's at home and just seems a little off or different, or their personality doesn't seem like them, right? And so those are patients where we say, maybe they've been having chronic headaches or something that might be going on that they'd benefit from a treatment hold or some steroids to see how they're going to feel. But the main thing is making sure, always being cautious and safe, as you mentioned, that we're not missing cancer that has spread or grown in the context of this. But it's always hard to know if the immune system's there, it's infiltrated, it might look bigger before, it might look worse before it gets better, which we would see with other types of immunotherapy called pseudoprogression. So it's really hard to, hindsight's 2020, but we just have to make sure patients are safe, supported, and closely monitored, as you mentioned. I
Again,
want to, yeah,
to emphasize, if you're at home and you're a caregiver and you notice these symptoms,
Yes.
please make sure that you are reporting these to your healthcare treating team, because they can help you and they do need to know, is this your disease or is this just related to your treatment? So
Absolutely.
never, ever hesitate to reach out when you don't feel like something is right.
Yeah, thanks, Anne. That's a really good point. And
Really good.
another side effect that I know Dr. Shields has seen too is these taste changes, referred to as dysgeusia. But just it means that things don't taste right. And unfortunately, I would say it happens in a fair number of patients, and it can be really challenging because I've had patients tell me like things taste like mud and like things just don't taste like they used to. And I know I love food, and so it's a tough one. And I wish we had better like supportive care. I wish we had better treatments to make it go away or improve it. And as of now, we don't so much. I know people are working on it, but that's another one just to be aware of. And we know that good nutrition is so important. I know
Yeah.
Dr. Shields, you've done some studies on this too.
Yeah. And it really, this is where our care partners become so needed because it's keeping, I know that Dr. Alder and you and I, we all three of us probably, you're at work, you get through your whole clinic day, right? And you go, oh crap, I forgot to eat, right? And so if you imagine that food doesn't taste as good or you're not craving it as much, that task doesn't, it doesn't remind you. You don't have that as obvious. And patients may still have a good appetite, but so much of our appetite is because we are, have that reinforcement of food tasting the way we expect it to. And so this is where our care partners are so key to really make sure that our smashers are getting all the nutrition they need, the hydration they need, so that we can keep them on therapy and also always getting plugged into your dietitian too. I do want
You
to be
know,
mindful of time.
Dr.
Yeah, go ahead.
Shields, we should make a plug though, because some of our
Yeah.
smashers have done a great job on our
Yes.
smashers Facebook page of putting tips out there as to what has worked for them and what foods
Yes.
taste better than others. So if you are part of our smashers Facebook, and if you're not, you should be, do a little search through our smashers post, because the smashers community has really come together to help each other with some tips on how to get around those taste issues.
Oh
Yeah.
gosh, Dr. Shields, we should like publish that.
Yes.
Because
Yes.
I would love to know. That would be
Yes.
great.
Yeah.
Our smashers are leading the way. I do want to be mindful of time. I want to touch quickly on ADCs and then I want to pivot a little bit. So can you just tell us what are ADCs and do they work in the brain? Are any FDA approved? Are they still in trials? Where are we at with these ADCs?
Yeah, really exciting type of treatment. So EDCs, they are what I usually describe them as is kind of smarter chemotherapy. And so what they do is they have a target, and then they deliver that chemotherapy more directly to that target. So there are a lot that are being studied now in small cell lung cancer. So the targets include DLL3, TROP2, B7H3, SEZ6, CCAM5. And so some of the ones that are a little bit further along, Infinatamab deruxtecan or IDXD, which is a whole lot easier to say, is one of our B7H3. That's been presented at a few of our big lung cancer meetings. And the really exciting thing is, seems like they work even in patients who've had a lot of treatments before, and they work both in the body and in the brain. And we've seen response rates upwards of 60% in both locations.
Mhm.
And so that's really encouraging. There's another says 6 ADC, the AbbVie is putting out, and AbbVie 706. And that drug likewise has shown really exciting results, both brain and body. There's nothing that's currently FDA approved, but I think lots of exciting trials, and hopefully very soon we will have an approval that will give us even more options to treat. And we know historically from a few other cancer types, these ADCs can do a really good job of getting into the bloodstream and into the brain. And I think there's a few different reasons. I think they have some more immune effects than was initially thought. I think they have what's called a bystander effect, which means even if they can't directly cross into it, they can still influence that layer into the brain. Lots of exciting research going on there too, but I'm glad they work well.
Yes, yes. I think we're eagerly awaiting these approvals of this new class. I think it's going to
Yeah,
really open up so much, such a game changer for our patients, our
absolutely.
smashers. I have one quick question from the chat, and then I want to ask you more about kind of thriving with small cell. But one of our smashers, it looks like, asked about liquid biopsies. Is there a role of liquid biopsies for monitoring brain mets, detecting anything currently that is out there for liquid biopsies and brain metastases?
So that's a really good question. It's evolving. I know sometimes we do liquid and or tumor genomics, which is like the sequencing of that DNA, RNA, that instruction manual to help make sure if there's any additional clinical trials, if there's any additional treatments or anything about the tumor biology that can help guide us. It's still, I would say, in early research. But there are some really cool assays that look at the circulating tumor cells in addition to some of the circulating tumor DNA. And I think that's a really exciting area of research. And it's one of the things that myself and some of my partners, translational researchers, are trying to see, can we predict who will respond to chemoimmunotherapy or to tarlatamab? Can we predict who will have toxicities? Can we predict maybe in conjunction with scans and imaging who may be at more at risk of brain mets? So early studies, early designs of some of these plasma assays, but another really exciting thing that's hopefully up and coming soon.
You know,
Yes, our smashers will stay tuned just to hear more updates on that. Go ahead, Anne.
absolutely. And one quick last question for me is that, you know, and
Yeah.
you've spoken a lot about research. You've talked about the ADCs, about tarlatamab, about how these drugs are working in brain mets. And I know that it's near and dear to you that
Yes.
clinical trials are including patients who have brain mets or previously treated brain mets. That's something that our smashers community ask a lot of us, as why am I not eligible when I've had a treated brain met?
Yeah.
So if you could just speak to the importance of that and how we've really gotten this knowledge that you've talked about today.
Yeah, Anne, thank you so much. That is really near and dear to my heart. Every single time I talk with a pharmaceutical company or industry partners, I always mention this. I know Dr. Shields does too. I know a lot of us do. We need to be inclusive. We need this data. You know, from the drug company's perspective, it really helps them to show that response in the brain. And for the patients, we want to give our patients the very best treatments as soon as we can, as early as we can. And so there are some tools that are coming out. Me and my team at Duke, I'm very fortunate to work with them. We published something called a GPA index. This was published in lung cancer recently. It's kind of like the graded prognostic index, and it takes into account multiple factors. And what the bottom line is that patients are living a lot longer, even with brain mets, even with leptomeningeal disease. And so we try and show mainly the companies that, hey, these patients are living a long time. Here are some data points that we found that are very meaningful to show that, you know, it will be beneficial to your trial. You shouldn't be worried about including these patients. Um, because, you know, my motto is always like every single patient should be offered a clinical trial, and especially with these patients who need it a lot, really need to be more inclusive.
That's great.
Absolutely. Absolutely. I want to touch on just quickly some
Yeah.
quick tips, while we're picking your brain, Dr. Alder, uh, about thriving with small cell symptoms, support, resources. What are some ways, some key tips that you think for patients to really thrive if they're impacted with small cell and particularly impacted by having areas in the brain like brain metastases? What are ways that we can regain strength? What are resources that they should explore? How do we help them on their journeys?
So yeah, great question. So first of all, have to do a huge shout out to the small cell smashers. I think that support, the camaraderie, that community is huge, and I love what you all are doing so very much. In addition to that, I love that a lot of the stigma is decreasing or hopefully gone because we know anyone with lungs can get lung cancer. It is no one's fault. No one did anything to deserve this. It sucks. So I think that that's been a really good key thing too. One of the things I talk about a lot is early use of palliative care. Palliative care can sometimes scare people because one little branch of that is hospice, and that means end of life. But the whole other tree of palliative care is really just symptom control. It's helping through a lot of these symptoms that we talked about that are related to brain mets, related to radiation, related to the treatments that we use. Nothing that we do is without risk of side effects. Even having cancer can make you feel really crummy. And their specialty is treating these symptoms, really helping to improve quality of life. So I think early incorporation and partnership with palliative care is really important. And then, of course, physical therapy, occupational therapy, building that strength, doing the daily activities, and helping with stretches and strengthening exercises. Nutrition is really important. Other types of supportive care, talking to people. We have cancer support programs, smashers, even a dedicated therapist. We all have, major life stressors, and small cell is sure a heck of a big one. And it's okay to talk to someone who is outside of your family and friend group. And so that can be really beneficial too. And always don't be afraid to speak up, ask for what you need, share with what you need. We are very thankful to have so many resources, both at academic centers, at community centers, at community sites like this. And all of us just really want to help connect you to the right resources. So please share what you're feeling, what you're thinking. We want to know, we want to listen.
And Dr. Alder, as we wrap up here, what what gives you hope in small cell lung cancer? What are you excited about, and what are some things we haven't touched on yet?
Yeah, we need another like half hour with everything I'm excited about. There's so many new treatments. So tarlatamab was a game changer. These ADCs, the antibody drug conjugates, the smart chemotherapies, they're a game changer. I think they're, hopefully be approved very soon. The new therapies in radiation, proton therapy, more precise, less toxic, precision medicine, learning more about cancer, about the genomics, the proteins. Um, I think these are all super exciting. I think I'm so lucky, Dr. Shields and I, the small cell community, both patients and providers, is just incredible. I feel like we all work together so much. And even like our community gives me a lot of hope, and it makes me it brings joy to my career and to my life. So that always makes me really excited too.
Dr. Alder, this has been amazing, and your passion for this and your empathy for small cell patients has been so evident. And we just thank you from the bottom of our hearts, from LUNGevity, from the Smashers, from Dr. Shields, for joining us today and talking about this really, really important topic of brain mets. And for our Smashers, please join us again next month for our Smashers fireside chat again. And don't forget to register for our Smashers Live. Thank you so much for joining us today. Thank you, Dr. Alder, and thank you, Dr. Shields, as always, for a great fireside chat.
Thank you so
Thank
much
you.
for having me, Dr. Shields. Anne, thank you so much to the Smashers. This was such a joy to participate in. And Dr. Shields, LUNGevity, and everyone, thank you so much for all the work that you do. It's so hugely meaningful.
Thank you, Dr. Alder. Thank you, and